Hi, Dr. Brian Kaufman, the co-founder, chief medical officer, and executive vice president of the nonprofit CLL Society. And I'm going to be presenting an important abstract from the American Society of Hematology's annual meeting in 2023. This paper discusses the continued benefits of acalabrutinib plus or minus obinutuzumab in chronic lymphocytic leukemia. And the bottom line is that chronic lymphocytic leukemia patients do better when their first therapy is acalabrutinib based compared to chemoimmunotherapy. Specifically, after more than 6 years of acalabrutinib alone or in combination with obinutuzumab, they had better progression-free survival and overall survival in all groups, high risk and low groups, who were treated frontline for their CLL compared to those treated with Chlorambucil and obinutuzumab. These results were presented by Dr. Jeff Sharman and his colleagues as part of the ELEVATE-TN treatment-naive trial called acalabrutinib plus or minus obinutuzumab versus obinutuzumab plus Chlorambucil in treatment-naive chronic lymphocytic leukemia, 6-year follow-up of ELEVATE-TN, presented at the American Society of Hematology's annual meeting in December 2023 in San Diego. In the way of background, we've already seen data about the superiority of acalabrutinib plus or minus obinutuzumab versus the combination of obinutuzumab and Chlorambucil, but this added 16 more months of data. So what were those results? Well, who were the patients? There was 535 patients were randomized. And the randomization was pretty equal. 179 received acalabrutinib alone, 179 acalabrutinib with obinutuzumab, 177 obinutuzumab plus Chlorambucil. The median age was 70, which is a little older than you see in clinical trials, but not quite as old as the average CLL patient. 63% had unmutated immunoglobulin heavy chain variable, IGHV, so a higher risk group. And 14% had deletion 17p or a TP53 mutation. What were the outcomes? At a median follow-up now of 6 years, median progression-free survival has not been reached for both acalabrutinib arms, with or without obinutuzumab. But median progression-free survival for those taking obinutuzumab and Chlorambucil was only 27.8 months. So half of the group on Chlorambucil plus obinutuzumab had progressed at 27.8 months. Not surprising, the high-risk group of 73 patients with deletion 17p or TP53 went only 17.5 months without progressing with obinutuzumab and Chlorambucil, but their median progression-free survival in the acalabrutinib plus obinutuzumab arm was 73.1 months and has not been reached for the acalabrutinib arm, suggesting results are similar that for acalabrutinib-based therapy, that it's agnostic to those high risks, that high-risk marker, unlike chemoimmunotherapy, something that we've known for quite a while now. There were 79 patients who crossed over from obinutuzumab and Chlorambucil to acalabrutinib. And first I want to say I'm really glad that the trial allowed that, because that's the only ethical way to develop trials. And for those patients, their second progression-free survival, or their time to the second disease progression or death, has not been reached. So it did work well for those patients, though those weren't really treatment-naive patients at that time. The estimated overall survival, so death from any cause, was 84% for A plus V, acalabrutinib plus obinutuzumab, 76% for acalabrutinib, and 75% for obinutuzumab and Chlorambucil. The small difference there is probably due to the wonderful salvage therapy, so people who got chemoimmunotherapy first could be then switched over to an acalabrutinib-based or some other therapy that would work very well for them. We always have to discuss adverse events. Low neutrophil counts were seen, as we'd expect, with acalabrutinib and obinutuzumab, and acalabrutinib in 31% and 12% respectively. Low platelets in 8% and 3% respectively. Diarrhea in 6% and 1% respectively. COVID-19 was seen, 9% and 7%. Pneumonia, 7 and 6%. And syncope or fainting in 5% and 2% respectively, and hypertension in 4 plus 5%. Things that we might worry about more: severe atrial fibrillation, hypertension and second cancers were reported in 2, 4, and 10% of the patients treated with acalabrutinib and obinutuzumab, and in 2, 5, and 5% of patients treated with acalabrutinib. More patients continued therapy due to adverse events. 21 or 38% treated with A plus O, and 18% of 32 patients treated with acalabrutinib, compared to progressive disease, which was only noted in 6 or 10 patients treated with A plus O, and 14 or 25 treated with A. So in other words, more patients quit the therapy, not because the therapy wasn't working, but because they couldn't tolerate the therapy anymore. So what can we conclude from this? It should no longer be any surprise to those who've been following what's been happening in CLL or reading the pages of the CLL Society's website that a BTK inhibitor-based therapy, such as acalabrutinib, has once again proven superior to chemotherapy-based treatments. In fact, trials comparing targeted agents to obinutuzumab and chlorambucil would not be ethical to start now, as there would be no equipoise or balance in the trial. This, however, was less clear when this trial started more than 6 years ago. It is encouraging to see the continued long-term response to acalabrutinib plus or minus obinutuzumab, and also not to see any new side effects emerging, though all CLL patients should take note of the 10% incidence of second cancers in those treated with acalabrutinib and obinutuzumab, likely a result of their impaired immunity from the disease itself and its treatment. Overall, a very promising and useful option for CLL patients. Thank you for your attention. Stay strong. We are all in this together.